They had to write their comp, and some of them are in the 60s. No, 70s a minimum.
If you don't pass these board exams, that's it. You don't get a residency spot. You don't become a doctor.
They've got to understand, for many of these students, it's the first time they've utterly failed. We're not pretending, you're repeating. You failed. The reason they ultimately made their peace with that was the credibility of the people saying, you're not good enough. And they would look at the three of us, decades of practice, decades of teaching. At the end of the day, you just have to swallow hard and say, if they say I'm not good enough, I'm not good enough, I guess I'd better get better, and they're gonna decide for me. So that second semester, I saw two things. Ultimately, the surrender to reality. You're not good enough. What are you going to do now? No one's going to fake this. We failed half the class. You're about to see a really important conversation of the three people that have gone into medical education and shifted to patient-centered learning, talking about how they've proved its success with medical students. So if you want to be a better medical student, come listen to the people that are changing the world and showing you a better way to do it. Well, hello everyone. Today we have a special valedictory meeting about the team that put students through the inaugural class at Western Atlantic University School of Medicine, and you're looking at the team that innovated, took the political hit, did all the work to do it. So let me introduce Dr. Nancy Selfridge, who is the person that took over all of the political responsibility, Dr. Eric Neilson, who actually did all the work, and then me, who offered all the peanut gallery commentary. It was way better to be me. So let me just set the stage, and then I'll turn it over to the team. So WAUSM was a new school, and the dean was someone that knew Nancy well professionally and said to her, we'd like you to come and do curriculum. And Nancy said, only if I get to do it the way I want to do it. No discussions. And they just said yes. And so Nancy started with a pretty much conventional course, PhD-linked teaching, except this is a semester system, and in the 5th semester, she was going to go completely over to patient-centered learning. And she had watched me do it at her previous university. She had watched Eric drink the Kool-Aid and become absolutely marvelous at it. And to her chagrin, because she takes a lot of pride in her clinical teaching, she was left way behind in the dust, but she knew she liked it. So she did the great thing of starting at WAUSM and getting Eric to come for the 5th semester. And he did. And I was having none of that. I mean, geez, I was doing this from the beginning. So I wangled my way to get invited doing some other teaching. And so you're looking at the three of us who did the semester. So I don't know, do we want to begin at the end and talk about the outcome, or do we want to walk the story through chronologically?
I just want to add this other dimension. Because Eric joined and because you visited us, honestly, that patient-centered teaching infiltrated the lower semesters. And Eric witnessed this because he had to do some additional teaching in the lower semesters as well. So right now, this is what we do.
Well, let's start with your inaugural class and the students we're working with, because I think one of the conceits of American universities is they start with students who are marvelous exam takers. And then when they pass exams, they go, man, we can really teach. Okay, well, let's go to people who by definition are poor at exams. And let me stipulate, this has nothing to do with the quality. We're not talking about how you're going to be in practice. This is your ability to do abstract concepts of math and English in a multiple choice format, whatever that measures. And these people are not good at it.
Yes. Yes.
So let's start with your inaugural class. Who you got?
Yes, and so we picked the majority of students that we picked came in at 2 standard deviations below the rock bottom of what is accepted as an MCAT score in the U.S. So I'm hoping that your listeners know at least a little bit of statistics to realize what that's saying.
So my understanding is the lowest MCAT score you can get is 470, and you had students whose MCATs were in the 470s.
We had students whose MCATs, we have accepted students whose MCATs were in the 470s, but primarily in the 480s and low 490s, and that's still in that 2 standard deviations sort of range.
Okay, so you're going to start with a small class, 16, am I right on that?
Mm-hmm.
Okay, and then we're going to go forward through the conventional semesters at that time until we get to 5th semester.
Yeah, and this the 5th semester program, and Eric took that over, teaching them and making the students actually eventually do these topical reviews day after day after day, week after week after week, using this patient-centered approach, identifying their knowledge gaps in terms of the facts that they have to retain, and they filled them in, and then ultimately the majority of them who have made it through have passed step 1.
Okay, let's set the scene. I arrived with the first semester, and Erica's taking the first fifth semester to go through. I've got to say, based on my experience, they brought as little subject-based learning as any medical students I've ever known, which is not much. And that's true across the board. That's not a criticism of your students. Subject-based learning does not stick. And so whenever they come to this, right, they bring very little with them. So Eric, why don't you talk about how we do patient-centered learning, and then you can talk about how you improved it as you went along.
Yeah, I think it's a great point, Philip, that these students, they pass all the tests, they do all the anatomy practicals, they learn all the facts, and then they get to a clinically focused sort of scenario or question, uh, something as classic as I'm having trouble breathing, and they don't know where to go next. They don't have that systematic approach. And once you walk them through, it's quite obvious the A to B to the C. They knew every factoid in that sort of process, and they often say, "Oh, I remember that," or "Oh, yeah, I knew that." But really, they didn't make the connections between each of those things from the various sessions that they learned.
Let's qualify that. Do you really have a fact if you can't retrieve it when you need it?
This is a very good question.
Right? I would argue that when you memorize something, you can only retrieve it if you're asked in the way that you memorized it.
Correct.
Well, when I ask you to use it, you don't have it. So I would call them functionally illiterate. However, they recognize a word on a memorizing sheet, it means nothing to them when you ask them to use it.
And I think that's the point of teaching in that kind of subject-based, factoid, very sort of narrow focus, these concepts. And I think what, the brilliance of having Nancy, who does a ton of work and a ton of teaching in the earlier semesters, is to really bring these concepts that initially we were doing in the fifth semester deeper and deeper, or earlier and earlier in the training of the student. Even if it's sort of, superficially clinical, just shortness of breath. Let's talk about that in the heart.
Okay, I mean, that's all well and good, but that first semester, Nancy had not started that. So what was it like when those first students come in and you go, shortness of breath, go, and they're just sitting there going, wow, 2 years, that's a good question, and I got nothing.
It was definitely a struggle. It was a lift for sure.
It was worse than that. Boy, we all forget the bad, don't we? Ask a no about childbirth. Oh, it was nothing. Well, I was there. It was nothing. Why didn't you go? It was not. It was horrible. I was there.
It was painful.
It was so obvious so early, and thankfully you were there to help, because we even sort of modified the semester to where we were providing, whole afternoons of additional support, and walking through the things that we had spent, 2-3 hours on in the morning, and we needed another 2-3 hours in the afternoon to really, for the second or third time.
Let's talk about that in detail. It's one thing to talk about in the abstract. Let's talk about what that looked like in detail. So, like most systems, you don't get to write your exam until you pass a standard that says you're going to pass the exam. Because if you don't pass step 1, that's a hole that's very difficult to get out of. So it's not only self-serving for the institution, it matters to the student. It's perfectly fair. And most systems, yours included, uses the comp score for doing step 1. You have to have a 70%. That's a 99% chance of passing step 1. What percent of that class of 16 was below 50? Most.
Yeah, absolutely.
Some were starting in the 40s.
Mm-hmm.
Just to give you a sense of how little they brought to this.
It's one thing when you're studying heart and you're getting successful at heart or lung. It's a whole nother story when you have to put everything together on one test. And now, it's a multi-organ system process, and you're struggling to figure out exactly which of the multi-organs they're talking about is driving this disease process, or that you're asking about in the question. This is one of the reasons I feel like these test writers they're brilliant. It's a great test. It's an excellent test. It's clinical. It's focused on core basic science concepts, and the links between the patient and the concept are beautiful. And they test you on stuff you just have to know it. It's a fair question, a fair topic. And I've heard you say it many times. I think it's totally true. But putting the whole patient together after a year and a half of med school is a challenging uh, lift. And we see, many students at many schools, particularly, international Caribbean medical schools, who struggle with this in a big way.
Let's talk about what you did do, because apparently I'm the only one that's actually remembering this childbirth in detail. So after probably a month, we still had over half the class that wasn't even close to 70. And so you took that group and said, you will show up in the afternoon, person to person with Dr. Tisdall.
Yeah.
And those poor kids, I'm in this little hot room with a blackboard, and you can't hide there. It's me with the eyes on. Go and show me. And I can tell you what it was like. It was real. No one had ever looked into their brains and said, show me how you think of the heart. Right there. Go and draw it for me. They'd always been hiding behind the 5 choices of a multiple choice question. Well, one of them's going to be right. And you get it wrong, you go, oh, well. That's really different than when someone says, draw me the heart and put the coronary arteries on it. And so those students went into that room with me, no hiding, and their lives are on the line. They wanted to rebel. But you guys said, the old guy clears you or you're done, so make your peace. One girl, actually, when she was really struggling, she actually took the weekend to fly all the way back to her hometown of Detroit from the islands to get her Ritalin. That's how committed these students are. And, once they embraced the fact that they weren't going to fake it, it was one of the most intense teaching experiences I've ever had.
You just see the mental shift. I mean, it just happens right before your eyes. That it goes from, I think faking it's a great word. You're just sort of pretending your way through this stuff, and oh yeah, I know that, and I can connect this word with that word, and like you said, it's not until you have to get up there and explain it, and we might be jumping ahead a little bit, but this is the transition we eventually started making with the 5th semester.
I think we've established the pain. There isn't anyone listening that can fully understand the pain of what I'm describing to them.
Yeah. Yeah. We all know you never learn something as well as when you're teaching it.
Oh, absolutely.
We have to get up there and start explaining and start, flopping our way through a topic when you're like, wait, actually, you know what? I don't have quite all the pieces.
I learn something every day.
Any given lecture, I come across this to some degree, right? Or you get a question from a student. And I never quite thought of it that way. Let me kind of wrap my head around that. It's one of the beauties of teaching. One of the wonderful things about teaching. So with that background that we all know, we were really pushing the student because we were seeing kind of the faking it in a way that was making connections, but not in that shift that you're talking about, where the student really has to take the responsibility of walking through this concept from, the structure, function, anatomy, all the way down to the molecular genetic drivers of a disease. And it just becomes so obvious when they do that to them where their gaps are. It's just a beautiful way of thinking about medicine and a way of demonstrating your mastery of the concept.
Okay, so I really understood the importance of having a Dr. Selfridge in the system at the end of that first class, because if you'll remember, they had to write their comp, and some of them were in the 60s, which was pretty close. And you were kind enough to invite me to the meeting where the business people wanted to advance them. And Nancy, I'm pretty sure that's why she invited me, was no, 70 is a minimum. 70 isn't you're good to go. 70 is the least. And half the class didn't meet it.
Right.
And she basically stood her ground. And those students, that was real, you know. Believe it or not, we remember the most painful one was Alyssa. Well, Alyssa is going to come on and talk about that experience.
That's good.
But all of them had to face the fact. And then, Eric, you got them for a second time through.
We've seen this with every group through so many years, and it's heartbreaking. You know, some of these students, they just try and give everything they have, and it just doesn't get them where they need to be. And it's literally where they need to be. If you don't pass these board exams, that's it. You don't get a residency spot. You don't become a doctor. So it really is a make or break type of test. This is why Nancy's so adamant about them being able to pass this on their first time. It does them no service to pretend that, you know, they can just manage this and hope that it happens. It has to happen. And you see the disappointment and frustration and anger and upset, and many students in this scenario, I mean, it's by the skin of their teeth that they didn't quite make it. So from their perspective, it's really doesn't seem fair. But again, we know how important this exam is, and you've got to set a standard, and you've got to hold that line, and rules are rules, and you can't bend those rules just because, you know, you think a student maybe could do it.
So, you know, obviously I'm in the room with these students. I know them extremely well every afternoon for weeks and weeks. And I got to tell you, for anyone listening from a system perspective, they've got to understand for many of these students, it's the first time they've utterly failed. We're not pretending, you're repeating. You failed. I think what everyone has to understand is the reason they ultimately made their peace with that was the credibility of the people saying, you're not good enough. So no one's going to argue with you and me, Eric, but underpinning that, well, everyone should understand that the steel fist under the velvet glove was Dr. Selfridge. I mean, without her complete backing, it wouldn't have worked. And they would look at the three of us, you know, decades of practice, decades of teaching. At the end of the day, you just have to swallow hard and say, if they say I'm not good enough, I'm not good enough. I guess I'd better get better. And they're going to decide for me. So that second semester, I saw two things. I saw, first of all, ultimately the surrender to reality. You're not good enough. What are you going to do now? The second was the group coming in knew no one's going to fake this. We failed half the class. And I think, and Nancy, maybe over to you, I think that was the beginning of your school culture.
I think so too. I feel fortunate because you realize I didn't really have to face any opposition at all. Isn't that nice?
No,
I mean, from
well,
the layers
absolutely.
up, from my campus dean all the way up to executive dean provost, no obstruction whatsoever. That's a lot of invested trust, I think. When we talk about our investors, they just stayed out of all the academics, except that the one owner said to me, "This can't fail." And I said, "Okay, but then when I say we're failing, you have to hear me."
Right. Okay, so now we come to the end of second semester and you still haven't got your certification. So you have to turn them loose. The whole plan collapsed in a heap. They would write step one and go to clerkship, all fell in a heap. They all go to clerkship without writing.
The not writing was because, you know, it just takes time to get all of this compliance stuff in a row. The ECFMG note that permits your school to have your students sit for step one.
And so what feedback were you getting from the person that was talking to them every week about how their learning was going in clerkship?
I think it was fairly positive. You know, what's interesting, well, you don't think so?
No, I was talking to them every Wednesday. What I knew they knew on the island was eroding.
So you have to realize that the clerkship, the teachers in clerkship don't really assess them for their step one knowledge.
They couldn't because they don't know the basic science.
Exactly, because they don't think about it themselves.
Right.
So yes, all of the feedback that they were losing ground, and we know this happens. As soon as students leave campus here, we know they're going to get an erosion of that basic science knowledge and connections unless they're always talking about it. And some of them figured this out and figured out ways of talking about it with other peers and faculty.
So now finally they do, then you actually went to bat yet again and gave them an exam prep course with me.
Well, you need to talk about how that went.
And that was a magical experience for me because it's now the third time they're doing the same structured patient-centered learning. And so now they're not starting halfway up. Now they're starting 2/3 of the way up, and they're actually really fun to talk to because they actually know something. The big difference I made that everyone should pay attention to was I was a small cohort. I only had 13. And I made them write me a multiple choice question on the day's topic. It was, you could look into their minds. It did two things. First of all, I could see their minds. And the second of all, it put them in the mind of the examiner. It nearly killed me. I got to tell you, when you're reviewing questions, each one takes you 15 or 20 minutes. It took me whole half days to do because they've got to be critiqued at real depth. And I got to tell you, over the 12 weeks we did that, they went from primitive to truly sophisticated thinking. They learned how to think, they learned how to test. It was an extraordinary process. And then they wrote, and what happened?
Well, we had 100% pass rate.
Didn't we though?
Yeah, which is way cool.
It is beyond belief. And so now we've got different students, don't we? They're different people, aren't they? We changed them.
Yeah, they are.
So Eric, you now go at the end of clerkship. Everyone but one passes step 2, because of course now they're different people. What was the feedback you got from all the mentors that came to the match party?
Philip, I think one of the reasons we were getting such good feedback from the third year clerkship experience was because the course prepared them so well for clerkship. I think they were just surprised to see medical students who had yet a robust differential. They could think through, they could talk about disease processes all the way down to the cellular molecular level. They just had this way of thinking that is not common of a medical student. I mean, you get, the classic medical student comes on the ward for the first day and starts talking about the TCA cycle or something. And, they're just throwing things out there that has nothing to do with the patient in front of them, but sounds smart and, sciencey or whatever. So the feedback was, although they were slipping in terms of their step 1 prep and, juggling both of that, the clinical responsibilities and shelf exams and, everything, you could see why the basic science starts to slip, especially if you don't talk about it every day. But on the clinical side, the feedback was quite good.
Well, they liked our students, right?
They liked students. They thought they had great bedside manner. They were, eager to see patients and, learn basically. And they were prepared for that clinical experience in ways that I think this course, although we talk a lot about basic science and the first 2 years, the whole point is to prepare you to be successful in the hospital, to be a successful future doctor.
You'll like this story. So I said to Alyssa, how's it going on the ward? She goes, well, I just never expect to know anything. So whenever I get asked, I just always know that it's going to be horrible. And so I'm always cheerful about it. And, part of what I took away from that is, by interacting with us so deeply, by having to face up to the fact that, no, you're not very good. And oh, by the way, you failed. You have to change. I think we sent a different student to the wards, and it's a student that's been handled. And so they're very agreeable. They don't expect to know anything. They're very humble. They're happy to be learned. They take their beatings really well because they've been beaten on us. I think we're sending a better student because they realize they're beginners.
They're beginners, and I just want to share a story because I was actually in bed by 10 o'clock on the night of the match party, but I got a call. Eric may remember Dr. Welke walking around with her phone and making sure that students had a chance to talk to me. And one of our students said, "Oh, you've got to talk to Dr. Tisdall and you've got to let him know he changed my life. He made me the doctor that I am. I credit him with this success." But he's very specifically said something that struck me. He said, "When I arrived here as a clerk, we were side by side with medical students from US medical schools, And there's some reputable schools in Chicago,
Prestigious.
prestigious, that will go nameless. And he said side by side with them, those students were asking him, how do you know that? How do you know how to do that? Talking about differential diagnosis and organizing thinking.
Well, because they actually were face to face. It is one of the ideas that I'm deeply wrestling with now, which is I don't think you can teach yourself medicine. I think it requires intense small group tutoring. You need someone to look you in the eyes and go, explain that to me. No, I don't understand that. Go draw it on the board. Yeah, okay, so you don't know it. Let's talk about what it is. And they couldn't hide from us. You look at the three of us here, there's no hiding from these old clinical eyes, are there? Right? And you can see that in the product. I don't know how to scale it, Nancy.
No, that's the problem, isn't it? I think about that all the time. We have nice small classes now that are manageable, right? Highly interactive, and we can get what we need out of students. Not a big lecture hall with somebody sitting in the back and taking a little nap.
So just make sure everyone gets their kudos here. I understand, Eric, when you were there, you got a standing ovation.
Mm-hmm.
Yes, they were all, quite how do you say, appreciative.
Well, they knew. No, it's not appreciative. They knew that if you hadn't been in loco parentis professionally, they wouldn't have ever been doctors. I think maybe or 3 or 4 of them, everyone else was handcrafted by the team. It's somewhere they couldn't hide from all of us.
Right.
So no, you deserve every bit of that. And sort of like the officer getting the medal for how the platoon fought. I took that as I took that as thank you for accepting the credit for the team.
Right. Well, the other thing that Eric did that was absolutely brilliant for many reasons is he took these topical reviews, and instead of delivering them himself, he made groups of students work together to deliver this as a presentation. So they essentially had to teach the material.
And let me just stop you there, Nancy. I was there when he did that. Just from a pedagogical point of view, it is really slow. It is agony to watch. You're just, oh, please get that word out. Oh, please. And it's painful.
Yes.
But
The classes are small enough that they just didn't do 1 or 2 of these. They did 1 or 2 a week. That's how, right? And so now think about the poise and the ability to sit in front of a group. Anybody who had the jitters to begin with by the end of this 15 weeks, 12 weeks, 13 weeks, 15 weeks, no more, right? No big deal.
right, nor getting things wrong.
Right. And here's the thing. They didn't know what group was going to be picked ahead of time to present the topic. So everybody had to prepare as if they were presenting.
Okay, so that was Eric's big innovation. It's really worked well, however painful it is for the teacher. How is it now that other semesters are watching this happen? They see the outcome, and Nancy, they're getting a big dose of you earlier.
Mm-hmm.
Are you starting to feel that cultural shift in your whole school?
I absolutely do. I feel so lucky because the first time I've taken on semester 5 was this semester.
We'll come to that.
Right? Yes, absolutely. But this cohort stepped in as a group, and they're so cohesive and they're so just upbeat. And they're not all best friends, but they like each other.
Is this unique to that class, Nancy, or are you developing a culture of professionalism and trust?
Well, I think the class is pretty unique, but guess what they've done is they are influencing lower classes as well, just based on their attitude. So they've been raving about this approach.
But it's a change, right? I mean, all the rest of us had flaming rebellion and anger. Where's that coming from? Do you think it's coming from trust? That'd be my first try, right? Do you think they trust you in the system now?
I think they absolutely trusted Eric in the process. And even though Eric, I know that was kind of bumpy with some cohorts, I think in the end, You know, students talk, and the culture somehow has shifted.
But I'm thinking about any outside institution watching this.
Yeah.
My sense of it is you have to prove yourself with the first semesters, and that success speaks for itself. And now you'll build a trust in the system that becomes self-fulfilling.
Yeah, talking about our success now reinforces the fact that, hey, you can count on this working for you.
So we're back to trust.
Yes.
Is that fair for anyone watching the system? You've got to do it right the first time, and success will be trust and then become self-fulfilling success.
Yes.
Real quick, I just say it's got to work too. The student has to walk out of each of these sessions feeling, wow, okay, I learned something. I put some pieces together. I can see how this translates to my success in the future. It can't be students up there just doing some fluff project and like, you know, putting up a couple slides and saying a few words and then walking out the door. It's got to be you or me or Nancy in the back of the room saying, whoa, whoa, whoa.
Exactly.
Steps we're missing here.
Okay, let's talk about creating tutors. Because obviously I was the first guy in the breach, and people have to understand, I don't think you could do what I did again, because I was teaching exam prep, which meant I wasn't part of a university. I didn't have any committees. I didn't have any learning objectives. It was me in front of 150 students who were going to write their exam in a month. And I had 42 hours to teach all of pathology, and I did it 10 times a year. So I would teach, modify, and I did that for 6 years. So, that's a 60 times iteration. And then then Eric saw me, but he's teaching real time. He's teaching Sims. So he takes me, tries the system we do, and he goes, well, this really works. So over a year or two, he does every system and then becomes me. So that's what you watched with some envy, although you were always cheerful about it, and it gratified me that you resented it so much. But so you watched Eric and me do this, and then and when I was on the island at WAUSM, I could still feel your mild resentment that we were getting better and you were watching it. So now we have to create a third person, you. So you're the next one. You've watched this a lot. You're teaching a lot. This is your first time embracing a pure patient-centered. How's it going?
I think this semester went well. And what I did because we have a small cohort and we only had a limited number of groups, 3 total groups. And so they would have to repeat at least once or twice per week. And what I started to do was pick up 1 or 2 topics to do myself.
Well, that's nice. That's the best. Go ahead. How is that going?
Yeah, it was fantastic. And what it did, though, Philip, and Eric can vouch for this too, is it changes the way you approach your teaching in the lower semesters, right?
Yes, it sure does.
And guess what? I invited other faculty in to come and observe because we have new faculty. And guess what? They get it.
Well, in all fairness, though, you selected these faculties. These are not inherited faculties.
And I selected them based on, are you open to this idea?
Are you going to be fun to teach?
Okay. Some were not only open, they actually said they'd been waiting and looking for something like this. So I think we're going to be able to duplicate effort.
Okay, so let's talk about you being 2/3 of the way. You're on the downhill slope now.
Yes.
You're already starting to teach the teachers, right?
Trying to, yes.
Spare us the modesty. We know exactly how good a teacher you are. You're a great teacher. Okay, so now you're pushing it into the lower groups.
Mm-hmm.
Are you now letting them take the lead and watching them? How are you teaching them to teach? They watch you, and then what?
So then the next step is I assign sessions to them, which I've done. I've started, and so I'm waiting until this next semester. And I'm not going to segue out of that and use my time for recreation. I'll be sitting in class and watching them.
I know you will. Okay, so even over the hump, you're now feeling confident bringing others along in the system.
I am. They have to be carefully selected, though. You know this. You've seen my struggles before with faculty.
Well, I'm asking because I have a very practical problem. In my new school, I have a senior administrator teacher who wants to change the system, but it's a pretty fixed system.
Sure.
And so I don't know how to say, you actually haven't done this. You might think you know how to teach, but trust me, if you haven't done this, you haven't done this. And so my thinking is this. I've asked her to come and take one of my ad hoc classes and
Yes.
just do something like edema so she can try it. What do you think? Is that a good idea?
I think it's a great, she needs to actually see what happens, right? And watch the student response to that. Yeah,
Because she doesn't understand what she can't do,
Correct.
I agree.
right? I mean, you think you know edema, and then I say, well, let's talk about Starling's forces, and you get this horrible sinking feeling. Yeah, that rings a bell, I think.
Right.
Let alone when you get really good.
Well, and it totally changes the way you are in the world in terms of thinking at this molecular level. Remember the conversation we had about extracellular matrix?
Absolutely.
And I've been reading tons about extracellular matrix now.
No, you do fall in love with the oddest things. I'm
You
deeply
do.
in love
You
with
fall in
extracellular.
love with it. Absolutely.
Yeah.
Yeah.
So then now we have to talk about how do we make more teachers so that everyone can do this, and then how do you change a curriculum on the fly? You're in a small system in which you're the totipotential cell, right? You get to make everyone obey your signals.
Sure.
And that's taken you what, 4 years?
Yes. It's been an evolutionary process, and it's been painful.
4 years. So yeah, don't think you're going to wave a magic wand.
No.
And you're just starting to get into the earlier semesters. You haven't done the change yet. You just got cooperation.
Got cooperation, absolutely. And because we were low on teachers, I actually got my fingers into a lot of the work and
Lucky
set up our
dog.
sessions. You know what I'm saying?
I'm
And
so
Eric did
jealous.
too. Eric did too. And some of that was just a necessity. And so once they're made, the challenge is how do you, even when you've hired good teachers from other institutions, but they're used to teaching the way they're used to teaching, how do you get them on board with this? And that's really the challenge.
I think that's where we all are. That's certainly where I am in my school, right?
Yeah.
And here's the problem that I'm facing. I'm taking a traditional school with subject-based learning first year, and now they're at the end of the second year. They're facing their national exams going into clerkship. And I go to teach anything, and it's like they have nothing.
Yes.
I was doing female pathology. It's like, did you do any anatomy? They have zero histology. There's not a chance you can even talk about what an epithelium is.
Yeah.
And you sort of go, I know you passed all your courses. So what do? They've got the system. They are passing their national exams. Everyone can cram well. They're all good exam takers on the continent.
Yes.
So how does this lovely administrator that really wants to make the change, and she's got me now, so obviously I've got the experience. How do you go about that?
Well, it just occurred to me, have her sit in a class where you're doing a clinical approach and the students don't have the basic structure function ideas that they need to solve problems. Because we know that this exam continues to morph into, can you synthesize material well enough to solve a unique problem?
Right. You can't have memorized your way to this.
You can't memorize your way anymore. And maybe having her experience that, like I did with you, knowing that we had taught students stuff in class because I knew the learning objectives. I sat in the classes, right? And then they were sitting with you and you gave them a clinical problem and couldn't even come up with the anatomy that they needed because they hadn't learned it in connection.
Okay, so we get everyone through step one. My serious doubts about keeping it going in clerkship. And so I think if we can switch subject a little bit, you guys, it sounds, I just heard this last week, you guys have made a major shift. You've actually put Eric in charge of clerkships.
Family medicine clerkship, yeah.
So Eric, talk to us. Okay, how, when you've embraced the suck, you've made the shift to clinical medicine, you passed your step one and you're just as smart as your mother said you were. Now you're in clerkship. How do you keep this going?
Yeah, I think that is the challenge. And I think, obviously step 2 is becoming a bigger and bigger exam.
What do you think? I don't think that states it. It's the only one with a grade.
That's the only one with a number. So, obviously the focus has to be, success in clerkships and understanding, how the shift from step 1 to step 2, what's actually different in that test. It's a much more clinical test. It's a much more what lab do you want to order next? What treatment are you expecting to, take care of this patient, kind of a thing. But there are still core basic science concepts that are the foundation to all of these disease processes. So the hope is that, there is this transition from what started as a really robust clinical approach to medicine in years 1 and 2 that will make this transition through year 3 as smooth as we saw the first group that go through.
What's the action statement?
Well, I think the action statement is sort of, now you're seeing the patients. Now you're seeing how a hospital functions, and being able to see that those core principles that we talked about in the first 2 years in action.
I'll stipulate that. Okay, so you have your student go in and they see their first diabetic and the urine protein's gone to 4+. How do you ensure that the student understood what happened at the trilamellar filtration unit in the AGs? How do you plan to measure them?
I think that is the $1,000,000 question. And I think, the gap between basic science and third year in all the literature that you read is of Grand Canyon size. It's been that way for a long time. If we think getting the basic science faculty on board is a challenge, imagine 500 clinicians who these students are rotating through. So this is another level of challenge. And I think, step one is just getting all of the faculty on the same page in terms of being able to teach similar foundational skills. You're talking faculty in different cities at different hospitals. This is the word insurmountable almost comes to mind.
Not a word in my vocabulary. Sorry,
I-
disallowed.
Yeah, I agree. So, we're going to have to figure this out. I mean, we're going to have to see.
I get it, but what are your thoughts?
I mean, one of the reasons that I think we have this triumvirate here is because Philip is working on this online presence and building a community. And I think the community could bridge this gap. I think that's one of the most important things it can do.
So let me give you a sense. I totally agree and understand that is the entire intent of the community. It starts with students wanting to pass exams. It then moves to students wanting to learn more from their patients. But what has delighted me is I think we've got to have all of our educators come in.
Yes.
And so I don't, what I'm working on now, Eric, is I'm getting these students ready for their national exams. And so how do I bring that to scale? Because now I've got 180 students a year.
Yeah.
I go into a pod and I walk up and go, 6 students got the message, 174 to go. Right? And so what I'm doing as we speak is I'm going to each organ system and I'm saying, what are the 3 most important ideas? And then I'm writing a question that tests it. And I'm going to try that. I'm going to try posting, like if you do, what's the critical idea in the heart? Tell me when I say ischemia, what's the critical pathophys, right? And so that's my start, is to say, you can come, you must know these 3 ideas. You know them, good. You must know these 6 ideas. But that's as equally true for the clinician as the student.
It is.
Right, so that's what I'm working on. And I got to tell you, it's so much more fun being the researcher than you guys. Okay, I'll give you an example. You know what I learned yesterday? You ready for this? You're going to love the question. So the single most heavily tested thing in rheumatoid arthritis of the big 3, is not DIP. Every one of you knows that. There isn't one who hasn't taught that 1,000,000 times, right?
Yeah.
But I get to be me. Why?
That's good. That's really good.
Okay, I'll let you dangle for a sec. You know what the answer is? How do you think about rheumatoid arthritis? You think about it as an autoimmune disease of the tenosynovium. Fair?
Yes.
Perfectly fair, right?
Fair enough.
Synovium turns into pannus,
Pannus,
filter into the fluid, and I get neutrophils. We're all happy with that.
Antibody accumulation.
Supposing I told you that the DIP, because it's at the end of the line, has very little synovium and only one little tendon with very little tenosynovium.
Makes perfect sense.
It is a little bit involved, but so much less than all the other ones that we don't think about it.
Brilliant.
Whereas when we go to osteoarthritis, well, now that's mechanical and the tips get beaten. But here's the other little pearl that I'm just so pleased with myself. I feel positively glowing over it. So osteoarthritis, but it's mechanical. So where does the itis come from?
Well, I get that. And so you don't see a robust inflammatory response, but there is some inflammation involved, obviously, or you wouldn't get the signals that you do, for example, for Rankel, right? And osteoblasts, yeah.
That's correct. And so I just can't tell you how, yet again, if you have a good pathophys, everything's easy.
Yeah.
So if you can do DAMPs, you can do OA. If you can do tenosynovium and antigen antibody complexes, you can do DIP versus PIP.
Cool.
And that's why it's so much more fun being me than you guys. I get to think about that all day.
You know, after all this time, because I've truly been teaching osteo and rheumatoid for, well, easily 7, 8 years, right? Almost a decade, I would say. I've never had a student ask me why does rheumatoid not affect the DIPs?
And what does that tell you, Nancy?
They're not thinking about it.
They're all memorizing. Tell me the answer and I'll get the exam question. They're not saying, how do you, right? And that, so let's use that as a marker
Yeah.
for how deep your culture is infiltrating. How often do the students ask you why?
Well, fifth semester, fifth semester, I got a lot of whys, and it was making me look stuff up constantly. It was
the best.
great. It was good. So, fingers crossed, maybe it'll seep down. Actually, the fourth semesters, some of those students ask why on a regular basis.
Right? It's so much easier to learn.
Yes.
You know, the transition to med school, just real quick, it's just so intense. You know, they just, it's drinking from a fire hose is the classic. You know, you're just trying not to drown this first year. The thought of asking why and having to learn even more stuff just doesn't even cross your mind. You know, you've had enough. You're just thinking, thank God it's not the DIP joint. It's just one less thing I have to worry about as I'm learning, you know, this disease process. But again, it goes back to the principles and the core basic science pathophysiology, and then you can answer every question.
Okay, so here's where I am in that thinking. How much of a subject do you have to carry forward from first year to second year to say, okay, that's worth teaching? And if it's less than that, then we're canceling the course because not enough happened to be worth the time. What percent?
I don't know.
30? 50? That's the question I'm asking now for my second year students, you know, because as you pointed out, drinking from the fire hose, what if we taught them half as much, but they carried all of it forward?
See, this is the struggle, isn't it? And how do you convince your faculty that they don't need to know this much detail? They need to have big ideas absolutely nailed.
Oh, yeah. Right. I mean, the clinicians that are saying, here's patient-centered, are measuring how well you taught that subject.
Yes.
So I would always say, you know, when I was doing my review classes, I would always start with heart because everyone loves the pump. And I would say, okay, you know, you just did anatomy. Why am I reteaching it?
Mm-hmm.
Well, did you teach anatomy? Or did you think that your subject stood alone as a valuable idea, not as the foundation stone that patient care is going to be built on? So how much do we need? Can you cut your courses in half, Nancy? But now you need mastery. Here's the difference, right?
Yes.
You can know 70% of everything or 95% of what you need going forward.
I would love that. I would love a curriculum like that where students progress forward based on mastery. But, you know, then the dilemma is, as you point out, how do we get together to decide what is the core content that you must bring forward forever?
That comes to this idea of a Gantt chart, right?
Yeah.
In engineering, a Gantt chart, when you have a big complex project, says what has to be done where in time so that you can, I've got a foundation, I can start electric, right?
Yes.
We've never done a Gantt chart on a medical student. And, you know, coming to a new school, which you guys haven't done in a while, but I do, the first thing you say is, am I allowed to talk about heart? Have they done heart yet?
Right.
So I would argue that going forward, given that we're the three that have all the arrows in their back, I would argue we should start mapping out ideas, Nancy,
Mm-hmm.
and say, okay, yes, they have this idea, so you can talk about that.
Sure.
Eric has the bigger problem. I think he has to map out everything they should know, and then he's got to say, you fill out your diary. I see that you did acute pancreatitis. Please fill this out for me to prove you learned from your patient.
Yes, because right now they just have patient case logs. They don't actually have to explain their thinking about it, right?
Well, I know what I would do. I would pull that out faithfully, not having proved I learned anything. But here's the problem. What were they reading?
Exactly.
So yeah, so those are the two projects that I would, if you two, as you have to start doing it, because I'm going to keep asking you how you're coming along. So as you do that, be sure, I would love to participate in that. I mean, that really goes to the deepest theory of what do you have to master to get to a patient, and then how do you use your patients to improve your mastery?
Well, you've made some headway with your 2 volumes of
Yes,
clinical pathophys,
yes,
honestly.
that's right.
That
That's the start, right?
that really helps.
And then the community, the team who apparently can't get a book published, have assured me that once we have it in the library,
Mm-hmm.
we will dynamically keep correcting it. So I can go into rheumatoid arthritis and now put a little insert, why don't you see DIPs?
Brilliant.
Right? So we need a dynamic, stop thinking about it as a textbook and start thinking about it as the resource repository of up-to-date, real-time, how are we thinking about?
Yes, brilliant.
Right? So that's my responsibility, he said, looking over at Allie. And you guys, I mean, I think congratulations all around. And now we start phase 2, right?
Yep.
Well, especially for you, Eric, because you have to deal with all those clinicians who think they're smarter than you, and half of them are. So that's not easy.
And Eric, traditionally, family medicine residency is one of not residency, sorry, clerkship is one of the hardest just because of its breadth. Really challenging for students. So I don't know if the shelf is still one of the hardest, but I remember on my clerkship test, I even had a question about tularemia.
No.
Uh-huh.
How
I
inappropriate
remember it
is
just
that?
because I happened to remember that one factoid, and everybody was mad at me.
Well, as they should be, wrecking the curve like that. Yeah.
Yes, no kidding.
Okay, well, we've had our nice self-congratulatory meeting. Eric, you owe us 2 things. One is you got to share your learning of ultrasound. I just can't imagine how funny that's going to be. And the second thing is you've got to document how it's going as you start to infiltrate into the system. Please keep notes so you can share that experience. Nancy, last words.
Onward. Right? Upward and onward.
But what are your technical plans? You know, when you come back on to talk about what you're doing, what are you going to be talking about? What you've been trying? What's going to be on the agenda?
It's going to be, solidifying 5th semester, right? Because I got an easy cohort, honestly. They're kind and gentle and loving and enthusiastic, but not all our cohorts are like that. So how does this work with a group that is a little more resistant? I need that practice, right?
2 things for you, right? Talking about the student experience, but also, you're leading the way of learning how to do this.
With the faculty as well.
I mean, my big change is I'm actually all the way back at the beginning in an institution that's talking about patient-centered learning.
Yes.
Okay, well, that was really fun to catch up, everyone. Everyone happy to do this again in a month or 2?
Oh, it'd be fun.
All right, see you then. Bye for now. We are building out a new medical school companion app. We'll post more details as we get closer to launch. See you next time.